Okay, so in flaviviruses, we'll start with yellow fever virus. Yellow fever virus is both a flavivirus and an arbovirus, which means that it is transmitted by an arthropod vector. In the case of yellow fever, the arthropod that transmits the virus is the Aedes mosquito. Yellow fever is characterized by chills, fever, black vomit, and headaches. The vomit is black because it contains digested blood. The virus infects hepatocytes, causing patients to have jaundice, which can help you recall why it's called yellow fever. Let's cover the other important flaviviruses which are in this category. You can see here that hepatitis C is a flavivirus. I'll discuss this collectively with the other hepatitis viruses in a second. You're less likely to come across St. Louis encephalitis and West Nile virus on the board exam. Probably the most important of these to know is dengue, because it is the most common arbovirus. It infects macrophages. An interesting thing can happen where a person already infected with dengue can get a second infection by a different serotype of dengue, and antibodies against the first serotype will actually increase and cross-react. This will cause dengue hemorrhagic fever, or DHF for short. DHF is a very serious disease and presents with fever, a hemorrhagic tendency with bleeding commonly from the skin or nose, and a drop in platelet count. The patient typically presents with shock, and so does the doctor who has to see this. Moving on, rotavirus falls under the category of reoviruses. This RNA virus is the most common cause of fatal diarrhea in children. It is highly transmissible via the fecal-oral route and seen frequently in the winter in daycare centers and kindergarten. The virus leads to destruction of the villi in the GI tract, which will lead to loss of sodium and potassium, leading to fluid loss as well as electrolyte imbalances. Treatment involves supportive care, but actually there are 2 vaccines available, both of which contain live rotavirus. Rotavirus, like the influenza virus, is segmented. This implies that it can undergo reassortment, just like the influenza virus. Also, remember that it is a double-stranded RNA virus, which is unusual. Alright, let's take a moment here to remind ourselves of the viruses that are spread through the fecal-oral route. They are norovirus, rotavirus, which both cause gastroenteritis, adenovirus, and enteroviruses of the picorna family, namely polio, echo, Coxsackie, and Hep A. Just one last thing. There is another reovirus you could hear about. It's called cultivirus and causes Colorado tick fever. I must say, this is a very low-yield virus to memorize. Alright, influenza viruses. We've mentioned this several times before. Remember that it is an orthomixer virus. Again, remember that it is an RNA virus with a segmented genome, actually 8 segments. We've already talked about reassortment. Let's show those images again. You can see that these 2 viruses have 8 segments each. When these 2 viruses infect the same cell, they can reassort and actually reassemble the segments that they have. This process, called genetic reassortment, results in genetic or antigenic shifts. Because this is a big change to the virus, to which even a person who has had influenza would not have sufficient immunity, this causes pandemics. However, influenza also causes epidemics, which I'm sure you've heard of. The etiology of epidemics is not reassortment. It is random mutations in the genome that create genetic or antigenic drifts, which are far more common and less serious. So let me just highlight this again. Antigenic shift causes pandemics and is caused by reassortment, whereas epidemics are caused by antigenic drift, aka random mutations in the genome. The influenza virus contains 2 types of glycoproteins on its outside surface that contribute to its pathogenicity, namely the hemagglutinin and neuraminidase proteins. You can see these outer proteins in this image. I'm going to show you how you can remember the function of each. Hemagglutinin proteins allow the virus to attach to and enter cells by binding to sialic acid sugars on respiratory epithelial cells. On the other hand, neuraminidase is an enzyme that allows the virus to exit the cell by cleaving the sialic sugars that are bound to the mature viral particles. The way that I like to remember this is that hemagglutinin helps into the cell, so it is saying, hello. On the other hand, neuraminidase helps the virus to leave. The cell is kicking out the virus, saying, no, you can't stay over. Yes, I know, this is quite lame, but it'll help you remember this. Hemagglutinin for hello, and neuraminidase for no. It even rhymes. Also, remember the neuraminidase because it is the target of antivirals such as oseltamivir, also known as Tamiflu, and zanamivir. Alright, another time for flash quiz. So, genetic reassortment in influenza results in antigenic what that leads to epidemics or pandemics? What about random mutations? They result in antigenic blank, leading to pandemics or epidemics. Yep, you got it. Genetic reassortment results in antigenic shift leading to pandemics, while random mutations in influenza result in antigenic drift leading to epidemics. Let's move on to rubella virus, which is a toga virus. Rubella presents with fever, post-auricular tenderness, lymphadenopathy, arthralgias, and a fine maculopapular truncal rash that begins on the head or neck and spreads down. If you had rubella, wouldn't you want to wear a toga? In children, it causes a mild disease, but it can readily cross the placenta and is highly teratogenic as a congenital disease. It is the R in the tortuous infections, which we'll come back to. Congenital rubella can cause deafness, blindness, and/or heart and brain defects. Remember that rubella vaccine forms a component of the MMR, or measles, mumps, and rubella vaccine. The rubella part contains live attenuated virus. The other toga viruses are far less common to show up in the boards. There are two forms of encephalitis, Eastern equine and Western equine. Equine means horse, so if you see mention of horses and an encephalitis, think of these two viruses. They are arboviruses and are transmitted by mosquitoes. Alright, so we're continuing with the list. The paramyxovirus family contains the following viruses: parainfluenza, RSV, measles, and mumps. Paramyxoviruses are the most important causes of respiratory infections in infants and young children under the age of 5. Let's start with parainfluenza. Parainfluenza can cause the common cold and croup. Croup, which is also known as laryngotracheobronchitis. What a wonderful mouthful, isn't that? Laryngotracheobronchitis. It affects the larynx, trachea, and bronchi with symptoms such as fever, a characteristic hoarse barking cough, laryngeal obstruction, and inspiratory stridor. Remember in particular the barking cough and stridor because these are important keywords to clue you in to a child with croup. Next we have RSV or respiratory syncytial virus, which causes an acute viral infection of the lower respiratory tract or bronchiolitis in young children. It infects almost all infants by the age of 2, with symptoms resembling those of the common cold. The interesting thing about RSV is that it is the #1 cause of pneumonia in infants, largely because it attacks while maternal antibodies are still present. Interestingly, infection doesn't prevent reinfection, although the second infection will be less severe. Here is an image of a paramyxovirus. Paramyxoviruses contain several structural proteins. You should remember the F or fusion protein, which causes fusion between the viral envelope and the respiratory epithelial cell membrane, mediating viral entry into the cell. You may be wondering, why is this relevant? Well, because palivizumab is a monoclonal antibody against the F protein. It is used to prevent RSV in children at high risk. Treatment for RSV is usually supportive, but in severe cases you can treat with ribavirin. Next up, we'll discuss the paramyxovirus that causes measles. Measles has a classic viral prodrome that is commonly referred to as the 3 Cs. The 3 Cs are cough, conjunctivitis, and coryza, which is a word to describe a head cold. Pathognomonic complex spots are 1 to 2 mm blue-gray macules on an erythematous base that typically arise on the buccal, gingival, and labial mucosa within 2 to 3 days of symptoms. The characteristic rash of measles is an erythematous maculopapular rash that typically begins at the hairline and spreads downward over the next 3 days. Think about pouring red paint over somebody's head and watching it spread on the head and face first. Then it'll spread on the shoulders, trunk, all the way down. I've made a little drawing here to help you remember this. This is how the rash of measles spreads. It's different from the rubella rash, which is more truncal and doesn't involve the extremities as much. The direction of the spread is the same though, head downwards. Complete recovery from measles generally occurs within 7 to 10 days from onset of rash versus a 3-day rash in rubella. The MMR vaccine, which I've already mentioned to you, is a live vaccine that will protect against measles, mumps, and rubella, hence the initials MMR. Booster doses are given for measles and mumps. Lifelong immunity occurs in those who recover from the disease. Treatment for measles is with vitamin A or ribavirin. Uncommon but very severe sequelae of measles can include post-infectious encephalomyelitis and subacute sclerosing panencephalitis, or SSPE as I've written here. SSPE is a chronic progressive encephalitis that causes inflammatory white and gray matter lesions of the brain that occur 6 to 15 years after apparent resolution of measles symptoms. Symptoms of SSPE include neuropsychiatric changes, seizures, coma, ataxia, and myoclonus. It is similar to PML caused by the JC virus, but JC virus usually affects the white matter only, and you only see PML with immunocompromised patients. Finally, mumps is our last paramyxovirus, which is acquired through respiratory droplets. It is characterized by inflammation and swelling of the parotids, known as parotitis, inflammation of the testes, known as orchitis, and inflammation of the meninges, known as meningitis. You can see the initial letters here spelled POM. Think of pom-poms. And when you see parotid glands that are swollen, like in this poor boy, you'll see why pom-poms is a really good mnemonic to help you remember this. Also note that the inflammation of the parotids causes displacement of the earlobe and is accompanied by pain and tenderness. We now have the last component of the MMR vaccine. The MMR vaccine is important for prevention of this disease. Remember that it is a live vaccine, and therefore it stimulates cell-mediated immunity. Question: can you give the MMR vaccine to HIV-positive patients? Yes, you can. It is the only live vaccine approved to give to immunocompromised patients. The rabies virus is a rhabdovirus with a characteristic bullet shape. This is a scanning electron micrograph of the rabies virus. Can you see the bullets? The virus is secreted in animal saliva and contracted by humans through the bite of a rabid animal. The fruit bat is a potential host for rabies. Reservoir animals include bats, raccoons, skunks, and less commonly in the US, dogs, since in the US most dogs are immunized. Following local inoculation after the bite, the virus binds to nicotinic acetylcholine receptors and travels via retrograde transport from the peripheral nervous system into the central nervous system. The incubation period may be weeks to months before symptom onset occurs. The clinical symptoms begin with flu-like symptoms such as fever, malaise, anorexia, and fatigue that progress to seizures, photophobia, hypersalivation, and hydrophobia, also known as the fear of water. Pain and paresthesias at the bite site is common. If you need a refresher on this, go look at the pharmacology section on cholinergic versus anticholinergic effects. Cholinergic activation leads to secretion of fluids like saliva and lacrimation. So when you think of the typical rabid dog that's salivating, remember that the rabies binds via acetylcholine receptors. The hydrophobia is actually due to the slow paralysis of the jaw and throat and painful swallowing, which makes patients fearful of drinking fluids that they are presented with. The final symptoms include paralysis, which may lead to respiratory failure and coma. So what do you do if someone is bitten by a suspected rabid animal? If this happens, post-exposure prophylaxis should be administered in the form of the killed rabies vaccine and human rabies immunoglobulins. Rabies is one of the few infections where post-exposure vaccination can be used to prevent the person from actually manifesting the fatal encephalitis. Unfortunately, if the patient has established rabies, it doesn't have much effect. It's too bad that rabies can't be diagnosed until it is too late to treat. Laboratory diagnosis is by fluorescent antibody staining of tissue from the nape of the neck, or by PCR of spinal fluids. Negri bodies or cytoplasmic inclusions in affected neurons are the hallmark diagnostic finding. You can see them in this image. They are usually found in the Purkinje neurons of the cerebellum.